Greetings and welcome to the Lurie Children's Sleep Medicine Roundtable. We are in session 4, and I'd like to introduce Dr. Thuan Dang. Today, she's going to be talking about parasomnia. But before we get to Dr. Dang, I'd just like to remind everybody that this session is being recorded, and the link to this recording session will be sent to you later so you can view and share with your colleagues. I like to encourage everybody to ask questions. You could type them in during Dr. Dang's presentation, or we can go live with your question after the presentation. But without further ado, I'd like to go ahead and send it over to Dr. Dang. Dr. Dang, I'm going to stop sharing my screen, and you can go take over the computer.
Great, thanks so much, Chad.
You're welcome.
Good afternoon, everyone. I am Thuan, and I am one of the sleep medicine physicians for the Lurie Sleep team. And today I want to talk about parasomnias, which is a quite frequent concern that we see in our sleep clinic, and I'm sure you see in your general pediatric clinics also. So I'm going to start my presentation and we'll get started. I don't have any disclosures today, but I really wanted to talk about parasomnias because by definition, they are an undesirable physical event or experience that occur during entry into sleep, during sleep, or during arousals from sleep. And they're separated into non-REM parasomnias and REM parasomnias. When looking at the different stages of sleep, non-REM sleep is broken into stage 1, stage 2, and stage 3. The lighter stages of sleep are known as stage 1 and stage 2. Stage 1 is really the drowsiness part of sleep. This is when the patients or even adults will kind of report that their eyes are feeling heavy. They're kind of getting that feeling like they want to drift off into sleep. We usually see a decrease in the frequency of the brainwave activities going from alpha, which is 8 to 13 hertz per second, really more into theta range. And this is stage 1 really occupies about anywhere between 5 to 10% of the total sleep time in the overnight duration. Stage 2 sleep we see is really characterized by what we call sleep spindles as well as K complexes. These are two very defining characteristics of stage 2 sleep. What's really interesting regarding parasomnias, especially non-REM parasomnias, is really stage 3 sleep, because this is the stage of sleep that we see many of the episodes that parents will report seeing overnight. And what we see during stage 3 sleep, which is slow wave sleep, also known as deep sleep, is there's a significant slowing in the waves in comparison to, for example, the stage 1 and stage 2, or even REM sleep. As you can see, the waves get significantly larger in amplitude and slow down to what we call delta frequency, which is measured at anywhere between half to less than 4 hertz per second. And the defining characteristics really for non-polysomnogram readers for REM sleep is really the existence of rapid eye movements that define rapid eye movement sleep. Regarding sleep architecture in children, non-REM sleep can usually last anywhere between 70 to 100 minutes after sleep onset. And there's typically about 3 to 5 sleep cycles throughout the night. Typically in children, the first part of the night, more non-REM sleep is part of the sleep architecture. This is what we call a hypnogram, and this details out what stages of sleep a patient for this particular patient went through during the night in our sleep lab. And you can see that the top bar is the awake portions. And then the patient will actually go through the different stages of non-REM sleep, which is stage 1, stage 2, and stage 3. And then the green bars signify the periods where the patient was scored as having REM sleep. It's very typical to see that the first part of the night, really the first third of the night, more time is spent in non-REM sleep. And as you can see for this patient spent quite a bit of time between stage 1, 2, and 3, and you could see the stage 3, the slow wave sleep, the deep sleep. And really for the later parts of the night, more time is spent in REM sleep, and REM cycles typically get progressively longer and increase in duration. When thinking about parasomnias, or what the International Classification of Sleep Disorders classifies as disorders of arousals, there are certain criteria that need to be met, including that these episodes are recurrent episodes of incomplete awakening from sleep. Parasomnias really are a almost transition or between awake and asleep, where it's actually a disassociation, where there are characteristics of being awake as well as characteristics of still being asleep. Patients usually are not able to respond to the efforts of others who try to intervene or redirect them during these episodes. There's usually no cognitive or dream imagery. If patients are awakened during these episodes, they really have no recall of dreams, unlike patients who report nightmares and are able to really vividly recall what their dream is about. There's usually partial or complete amnesia for the episode. So children in the morning, when parents ask about, do you remember what happened last night? You were crying, you were talking. Many children will look at their parents and say, I don't know what you're talking about, or I don't remember that at all. And the disturbance cannot be explained by another sleep disorder, a mental disorder, medical condition, medication, or substance use. As noted in the earlier slide about the distribution of the sleep stages and the sleep architecture throughout the night, events for parasomnias, especially really disorders of arousal, usually occur during the first third of the major sleep episode, because that's when most non-REM sleep will happen. And individuals usually continue to appear confused and disoriented for several minutes or even longer following the episode. One of the common parasomnias that many parents will report to me when they're in clinic are what we know are as confusional arousals. So this disorder has to meet the general criteria for the non-REM disorders of arousal that I just reviewed. And usually the episodes are characterized by a very confused state that usually occurs while the patient continues to stay in bed. And unlike the other two parasomnias, which I've discussed briefly, which are sleepwalking or sleep terrors, there's no terror or ambulation outside the bed. So most of these episodes continue to happen while the patient is in the bed. These episodes also lack any autonomic arousal, which is more consistent with sleep terrors, and I'll discuss that in the later slides. Prevalence in children with confusional arousals for children ages 3 to 13 years of age is approximately 17.3%, with a lifetime prevalence of 18.5%. Usually as children get older, the prevalence decreases, and studies have shown that in children ages 15 years and up, confusional arousals have an incidence of anywhere between 2.9 to 4.2%. These episodes usually appear around the age of 2 and typically diminish after 5 years old. I'm going to play this video now of a very typical confusional arousal that we see, or at least hear about in sleep clinic. As you can see, the child was sleeping and actually was able to rise up from bed, looked briefly around, and that's actually when he alerted his mother to see that he had an arousal. Surprisingly, I didn't continue this clip for the sake of time, but he actually was able, she just reached out to pat his arm, and he actually laid back down and continued to sleep. Sleepwalking the disorder has to meet the general criteria for the non-REM disorders of arousal, but these arousals are usually associated and have to be seen with ambulation or other very complex behaviors out of bed. The lifetime prevalence can be as high as 18.3%, and in a Swedish study of children 6 to 16 years of age, the incidence was as high as up to 40%. It's difficult for us I do not have an example of a sleepwalking episode, but most sleepwalking episodes usually start with a confusional arousal. Some can include some sleep talking, and you can see some complex behaviors start to develop. So I'm going to show you an example of if this child had not been intervened with his mother, he probably would have started to actually ambulate out of the bed. You can see it's classic to his earlier confusion arousal where he sat up. This time he actually started to vocalize to his mom. And unlike the earlier episode, he's starting to exhibit some complex behaviors. He's starting to rub his face. Mom tries to lay back down with him, but you can see he's actually not resisting her, but he's actually showing some complex movements where he's trying to sit up. It looks like he's trying to stretch out his legs. He's turning to the left. He's realizing, or at least in this dissociation state, is aware of the fact that he's tangled up in wires and is trying to navigate around them. And so although this is not a true sleepwalking example, I do think that if his mom had not been there, he might actually have been able to start ambulating or making the complex movements to ambulate out of bed. You can see his legs are actually flexed. It's almost like, and now he's extending. And he's still in a very confused state, is very incoherent when talking to his mother. Unlike confusional arousals or sleepwalking, night terrors present the most distress to many parents, not as much to patients, because as one of the diagnostic criteria, many patients have amnesia and they don't remember these episodes, but to parents, they are very disturbing because what really distinguishes night terrors are that there's a very alarming vocalization, such as a frightening scream, and there's really signs of intense fear, including dilated pupils, increased heart rate, increased respiratory rates, and a lot of parents will report that their child is extremely sweaty during these episodes. And the diagnostic criteria the difference between the international classifications of sleep disorders and the DSM-5 are fairly similar in regards to the clinical manifestations of sleep terrors. Once again, there's very little to no recall of dreams or retrograde amnesia of the episode. For DSM-5, they do include that there can be some significant distress or impairment in social, academic, or other areas of functioning. And the episode cannot be explained by another mental or psychological disorder, and the episode cannot be accounted for by use of illicit drugs or abuse of medication. I see that there's a chat. Oh, Julia, I am going to address the known triggers for the parasomnia events in a later slide. And so this video shows a very classic night terror, and I'm going to play it and then we'll discuss some of the clinical manifestations.
Dr. Dang, while this is being played, is it common for parents to be in the bed with them during sleep studies?
It sometimes it depends on the child. Some kids get really scared when they're in the sleep lab, and so sometimes it's helpful for parents to be in the bed with them. Usually we encourage parents not to co-sleep with their kids because we want to have them have, as much of a normal sleep environment as they are at home. But sometimes we do have parents that co-sleep with their kids at home too. So it really is on kind of like parent comfort. And also, this mom was actually pretty good about getting out of the bed. She just happened to have fallen asleep when for this specific episode. And this night terror actually occurred during the sleep study at the later half of the night. So she had just been really tired with all the previous awakenings and just didn't make it out of the bed after she fell asleep.
Thank you.
And so you can see in the video that the sleep terror clinical manifestations it's a really sudden awakening from pretty much the quiescent sleep, because once again, this usually happens in the first third of sleep when non-REM sleep is happening. And the movements, as you can see, the child started really flailing his right arm. And then, he sat upright. He didn't jump out of bed, but he definitely was screaming. He appeared very panicked, was frightened. You could tell that he was very confused and incoherent. His disorganized verbalization, and I really couldn't make out exactly what he was saying, but he definitely was trying to say something to mom. And really, what was really different in comparison to the other two videos is that mom had a much more difficult time consoling him or getting him to kind of like lay back down, because as you could see, she was trying to wrap her arm around him and he was actually even pushing her away. And so really, this really shows that during the sleep terrors, and really for most parasomnias, kids are really difficult to arouse, especially during night terrors. They're hard to console, and actually attempts to try to console the child or even wake up the child may actually make the episode even longer or make it actually more frightening for the child if they are to actually be awakened out of sleep. And so the sleep terrors prevalence, the typical age range is between 4 and 12 years of age, and the peak age is usually between 5 and 7 years of age. There's an estimated prevalence of about 1 to 6.5% among children 1 to 12 years of age, but as high as a prevalence of up to 14% has been reported in certain cohorts, with a lifetime prevalence of approximately 10%. It's pretty uncommon after puberty to have sleep terrors. And looking in the younger age groups, it's generally more common in boys than girls, and there isn't really an explanation as to why. If sleep terrors persist in adulthood, both sexes are equally affected. But once again, since I concentrate on pediatric sleep, most of this talk is looking at the younger kids in the typical age range where this happens. There are some risk factors for increased frequency of sleep terrors and parasomnias in general. If there's any febrile illness or concurrent illness that can actually increase the frequency. There have been a few case reports that patients with more full bladders during sleep can actually have an increased frequency. A noisy sleeping environment or one that may have brighter lights. If patients have had excessive physical activity in the day or days leading up to a episode being noted, if there's been fatigue or emotional stress, separation anxiety, or even patients who have reported being victims of bullying, patients who have frequent headaches or sleep deprivation or poor sleep hygiene that lead to sleep deprivation, as well as patients with anxiety have also reported increased frequencies of sleep terrors. Certain medical conditions such as ADHD as well as autism spectrum disorder have also been associated with increased frequency, as well as the excessive intake of caffeine or alcohol. And when there is an underlying sleep disorder, such as obstructive sleep apnea, or periodic limb movements, restless leg, or even post-traumatic syndrome that may either be diagnosed and undertreated or not optimized, that can actually increase the frequency of parasomnias, specifically in the sleep terrors. And also medications, because we know that parasomnias generally arise out of non-REM sleep, stage 3 specifically. Any medications that can increase a child's ability to have more non-REM stage 3 sleep can also increase the frequency or the likelihood that a sleep terror can happen. There have also been some studies showing that sleep terrors have a genetic disposition where specific human leukocyte antigens have been identified in up to almost 40.8% of patients with non-REM parasomnia. It doesn't necessarily mean that if patients have this specific human leukocyte antigen that they're going to have a sleep terror or parasomnia, but that they are more likely to have it. And this is really seen in the familial patterns, because in children who have a first degree relative that has had a history of sleep terror, the prevalence of that individual being affected is about 10 times greater than someone in the general population that does not have a family history of any parasomnias. This is really seen when in the studies of sleepwalkers, where patients with up to 60, with both parents who reported that they had a history of sleepwalking as a child, that 60% would actually be affected with sleepwalking if both parents were affected, versus 45% with one parent and only 22% if neither parent had reported a history of sleepwalking as a child when they were younger. And also looking at twins, the condition was more common in monozygotic versus dizygotic twins, which once again suggests the familial predisposition. And so when I'm talking to patients and really parents, because as you recall, patients really can't recall or they're amnestic during these episodes, I really try to counsel that usually the episodes are really just one sleep terror in a major sleep interval. Interestingly, the videos used for this talk are the same patient, and it was interesting because we rarely capture parasomnias in a sleep study, and I'll talk about the indications of when you should do a polysomnogram. But it's just interesting because this patient was actually in a different sleeping environment. The patient actually had been referred for concern about snoring and concern for, is there sleep apnea that we need to assess? And we actually caught multiple different parasomnias throughout the night. And this generally really doesn't happen in the sleep lab. Usually most parasomnias really are limited to only about one episode per major sleep interval. Interestingly, also, I always try to tell parents, we rarely see the parasomnias during nap time, just because the timing of naps really does not give children much time to get into a long, prolonged stage of stage 3 sleep. And also, when I ask parents to talk to their kids in the morning about, do you remember the dream recall? And once again, most kids will actually not remember at all. And I always try to emphasize that to parents when we're talking about the clinical history. Parasomnias are really a clinical diagnosis, really based on just key history taking points of the description of the event, assessing the age of onset, how often the episodes are happening, are there any daytime symptoms, is there sleepiness, is there behavioral dysregulation, looking at recognizing that insufficient sleep can be a trigger, looking at how many hours of sleep per day the child's getting, identifying any emotional stress or social stressors in the child's life that have been recent, with the familial disposition, looking at the family history of sleep terrors or sleepwalking in the family, looking at intercurrent illness, and also a thorough review of the medications that may increase the percentage that a child may spend in slow wave sleep. Parents always ask me, does my child need a sleep study after we talk about the episodes that they are observing? And really, because parasomnias are a clinical diagnosis, we really don't recommend polysomnograms, because what I tell parents is, what I'm going to see is I'm going to see that your child is going to be in slow wave sleep. Your child's going to have increased muscle activation. There might be an increase in heart rate, but for the most part, we're going to see parts of arousal or awake muscle artifact that indicate more awake states. But then we're also going to see brain waves that indicate that your child is actually still within the slow wave sleep or non-REM sleep that these episodes occur from. The time that a PSG may be indicated is if the description of the episode is concerning more for a frontal lobe epilepsy, or whether it's a possible REM behavior disorder where there's actual movements out of REM sleep. That would be when a polysomnogram is more indicated, and that would be discussed with the patient after really kind of thorough evaluation and discussion of the episodes that the parents are describing. Sometimes I even ask parents if you have the time to try record, but once again, this is in the middle of the night. It's hard to kind of like grab a camera and try to record this for your child. But overall management of parasomnias really is reassurance that your child is actually getting into the, appropriate amounts of non-REM sleep, and that it's part of the developing brain. I always tell parents to really avoid interrupting the parasomnia episode, to really keep a safe sleeping environment, and to really, as you saw in the videos of the mother, she really just redirected her child back into a safe sleeping position and really didn't try to wake him up, which is what I tell parents, that is the ideal way to manage these episodes. If there are underlying conditions such as obstructive sleep apnea, periodic limb movements that can be addressed that could help decrease the frequency of these episodes, we can try to address those. Looking to make sure we limit any precipitating or triggering factors. Rarely we have to use medications because, once again, medications would have to, such as the benzodiazepine class, would actually decrease the amount of time a child spends in REM, not in non-REM sleep, specifically stage 3 sleep. So it's rarely required. And for most patients, if the frequency is disruptive enough, I actually talk to patients about actually having scheduled awakenings, with the idea is that if a child is having an increased window of time that the parasomnia would be most likely to occur, by having a scheduled awakening, you're actually kind of avoiding or kind of making sure that the child doesn't spend that much time, and then decreasing the frequency of the parasomnia happening. I know we're almost out of time, so I want to open up for any questions or concerns or any discussion points regarding parasomnias in young children.
What a great presentation. Thank you so much for that. While we wait for questions to come in, I'd like to know, you and I had talked earlier about telemedicine. Is that's helping that's helping you be able to see a patient or talk to patients a little bit on a faster level, correct? And can you tell us a little bit more about what you're doing with telemedicine right now with some patients?
Yeah, so the telemedicine has really allowed our team to, one, sometimes see patients for more expedited. We also see patients who have multiple medical complexities and comorbidities. So sometimes a telemedicine visit is really helpful for parents because they're just trying to get their medically complex child to a physical location, and it's a little harder. But then it also allows us to, what our team is hopefully working towards is in the future being able to do more multidisciplinary, where we're able to work with our sleep team, our ENT team, our behavioral developmental team, all in kind of like one visit using the telemedicine platform. So then that way we're really able to provide really comprehensive care to our patients.
That's great. This is going to be a very vague question, okay? So forgive me, but with the demand of sleep medicine, can you talk to a little bit about, when is really the best time to refer, or when should they be trying to treat maybe the patient in their office before they're referring to us? Is that too vague of a question to ask, or is there anything you can share with our audience a little bit about that?
It is really difficult. I'm sure my colleague, Dr. Clark, has talked about it too, but we've seen a lot of sleep issues become even more prevalent after the pandemic. And so currently, unfortunately, right now, our wait time is about 3 to 6 months, unfortunately. So I always say refer as soon as you can. We really do appreciate if the referring physician can reach out to us either through Epic or even just sending kind of a message to us, or even talking to our scheduling team as to why, what is the major concern. When I speak to parents, I always say, I can't guarantee everything, but if I were to grant you one sleep wish, what is that? And then that helps me kind of help focus the visit as to,
Sure.
what is the parent's main concern? So if any of our colleagues are referring to us, if you could just tell us, a one-liner of like, this is what I hope to accomplish with the sleep medicine consult, that can help us triage whether or not can we expedite this, can we try to, add this patient to a wait list. And that's what our team has been doing, is we've been kind of patients that we've been able to either kind of expedite or move up the appointment, it's usually because we've been able to connect with the referring physician and actually hear exactly what is the circumstance and what is the sleep concern.
That's an outstanding answer. So thank you very much for that. So it doesn't look like I have any more questions coming in right now, which is fine. So the other nice thing is you pretty much answered some of the other stuff that's on the slide here is connecting to you, whether phone, email, it's all on the slides here, folks. And or Epic or Rapid Connect. And of course, don't forget Lurie, MD, to reach out to Dr. Dang and our sleep medicine team. And I'd also like to remind everybody that today was the end of session 4 and we start tomorrow. We have 2 great sessions tomorrow. So first is our sleep studies session at session 5 at 7:30 in the morning. And that's with Dr. Trossman and Regina Palamo, who's our sleep center manager. And then for our first time that we've done these virtual roundtables is we're doing a special multidisciplinary discussion with Dr. Trossman in sleep medicine. And she's going to be talking sleep disorder breathing with our ENT specialist, Dr. Velika and Dr. Gargasoy. And that's at 12:30 tomorrow afternoon. So I encourage you all to be on that call and talk to your colleagues too and make sure they're aware of it. And if you are seeing this for the first time on a recording, on the slide here, you'll see our other sessions that we've had before this. You can go right on our YouTube channel and click on those topics so you can learn more about our sleep center program. But Dr. Dang, thank you for being with us today. And thank you for the rest of you who are joining us today. And we'll see you all soon. Have a great day.
All right. Thank you, everyone. Have a wonderful day.
Bye-bye.
All right. Bye-bye.